Hi, everyone. It's my pleasure today to introduce Dr. Sarah Victor, who's an assistant professor at Texas Tech. Dr. Victor is a clinical psychologist with expertise in suicide research, suicide prevention, non-suicidal self-injury. She has a particular interest in minoritized populations, particularly transgender individuals, and the relationship between minority stress and suicide risk. She has been funded by the American Foundation for Suicide Prevention. She also has R21 from NIMH. And I was fortunate to get to meet her when we were both at University of Pittsburgh, where she did her clinical internship when I was a postdoc. So I'm really excited today to get to hear what Dr. Victor has to share with us. Her lecture, Strong at the Broken Places, Leveraging the Strengths of Mental Health Providers with Mental Illness for Suicide Prevention. So thanks, everyone.
Wonderful. Thank you all so much for being here, both in person and virtually. I'm just very excited to get to talk to you about this sort of newer line of research that I've been doing related to mental health and mental illness among providers. So the reference, Strong at the Broken Places, in the title of this talk is in part from an Ernest Hemingway quote, "The world breaks everyone, and afterward, many are strong in the broken places, but those that will not break it kills." With the idea that often we think of challenges, difficulties, obstacles as, of course, challenging, as difficult, and not about some of the strengths that we can bring to our work after going through those difficult challenges. This is also a reference to a Japanese art, kintsugi. I apologize if I'm pronouncing that wrong, in which broken ceramics, broken pottery, broken objects are fixed with gold. And as a result, the places where those objects have broken are then actually stronger and potentially conceived of as more beautiful following those breaks. So using that as sort of a framing to think about the ways in which our experiences that we sometimes think of in a sort of a deficit-focused approach may actually allow us to empathize with and provide more effective support for our clients and patients. So in terms of the outline for the talk today, there's sort of four different categories. First, a little bit about my background, and then a little bit about the empirical work that I and others have done trying to understand experiences of mental health, mental illness, mental health difficulties, psychiatric disabilities among medical and mental health providers. Then talking about some of the barriers, both attitudinal and structural, that folks with these experiences face in medical and psychological training environments. And then finally, recommendations for things that we can do to improve both the support of folks in our field, as well as the care that we provide to our patients and our clients. So this first bullet point is a take on the phrase, "the personal is political," drawn from second wave feminism in the 1960s. And in this case, I think it's important because my personal experiences and my professional experiences certainly have some overlap and some areas of interest that I think are relevant to understand the context of this work. So this summarizes where I am now at Texas Tech, where I've been in terms of my training, both my bachelor's degree and my master's and doctoral degrees. The folks at the bottom of the slide are folks who've mentored me throughout my training at Stanford, colleagues now at UC Berkeley, Sherry Johnson, David Klonsky at University of British Columbia. And since I've already had a lovely introduction, I won't spend too much time here. And when people ask me, well, what do you study? My sort of Cliff's Notes 30-second summary is, I'm a self-injury and suicide researcher. That's the bread and butter of what I do every day. That's my area of focus. And I'm particularly interested in high-risk transitions and changes in risk over time. So using methods like ecological momentary assessment. So that's the focus of my R21, following people after they leave inpatient psychiatric care for suicidal thoughts and behaviors, as well as my American Foundation of Suicide Prevention grant looking at gender minority stress and resilience in day-to-day life among trans and non-binary adults. I always feel awkward with this slide, but it's relevant for the following slide. So why should you care about what I have to say? I have about a little over $500 million in grant funding as PI. My work's been recognized with Rising Star Awards. I've published a lot, and that work seems to be having an impact on the field in terms of how often it's cited and how often people are referencing it. So by sort of traditional metrics of what's expected of me in my work in my field, people say I'm checking those boxes. I'm actually currently undergoing early tenure review at Texas Tech. I'm in my 5th year. Why is that relevant? Because behind the scenes, I have had a lot of experiences which at first glance, people might see and say, oh, that means you're in for trouble professionally, right? So throughout my life, I've had severe recurrent major depressive disorder, thankfully currently in remission, as well as moderate generalized anxiety disorder, which was diagnosed a little later in graduate school. And these experiences have resulted in being in the chair as a client or a patient a lot. Had a lot of evidence-based psychotherapy interventions, a lot of different adequate trials of psychiatric medications, as well as interventional psychiatry approaches such as extended course of RTMS and intravenous ketamine. And because the major depression has recurred so frequently, I've sometimes been labeled as treatment resistant. I put that in quotes because I think it's important to acknowledge that term can sometimes be sort of loaded. And for me, I find value in that term referring to the illness, not to myself in a psychodynamic framing. So why put these couple slides in here? I think it's valuable. Other people in the field have done this before me, and those people's disclosures have meant something to me as a trainee and now as a faculty member. And we know from literature on stigma towards mental illness that these kinds of disclosures, having contact with and knowing someone with stigmatized mental illness, does seem to be associated with decreased adherence to stigmatizing views, and that the power of those kind of connections is actually stronger if it's somebody within your perceived in-group, somebody who you might otherwise respect. It's also valuable for me. Literature on concealable stigmatized identities suggests that holding those identities and trying to conceal them is associated with emotional and psychological strain. It takes a lot of effort to have to sort of hide some of these experiences. And I think it's valuable to be able to show a counterexample to some of these narratives that suggest that having these experiences are inherently disqualifying to being successful in these kinds of domains. I should also say, in addition to my research work, I am a licensed clinical psychologist. I've provided thousands of hours of care to adolescents and adults, often folks struggling with self-injury and suicidal thoughts and behaviors. I don't currently have a clinical practice, but I do currently train and supervise doctoral students in their clinical work. So this next heading is taken from disability rights and advocacy movements, in which conversations about people with disabilities, the framing is that these conversations and these decisions need to be made with folks most impacted by these decisions, these discussions at the table. And so this leads me into the part of the talk where I'll talk about some of the leaders in this work and also some of the empirical research talking about, other than just me, who are the folks in the field who have these experiences? How common are they? What does this us look like? So these are some really influential kind of leaders who have disclosed publicly their experiences with mental health and mental illness, primarily drawn from psychology, since that's my area. From left to right, briefly, Dr. Stephen Lewis at the University of Guelph, who is a colleague of mine in self-injury and suicide research. Dr. Kay Redfield Jamison, who has actually written several books about her experience with bipolar disorder. Centers Dr. Marsha Linehan, the creator of dialectical behavior therapy, who came out publicly about her experience with severe suicidality as a young adult, I think back in 2010 in the New York Times. Then John Rottenberg, who's a faculty member who's written about his experience with recovery after severe depression, as well as Dr. Stephen Hinshaw, who has written both about his family experience with a father with bipolar disorder and his own personal experience with anxiety. So these were the people who were kind of the faces and the names that I went through my training hearing about. And having these folks actually have these conversations was tremendously important. But what we noticed, and as I started to have conversations about this with others in the field, was that people were typically waiting until they were quite senior, full distinguished professors, written books, lifetime achievement awards, right? And that makes a lot of sense because you at that point have more sort of professional credibility and stability to say, I can take this risk. And yet, a lot of times for folks more junior in the field, it felt like, well, I have to wait, maybe in 10 years, maybe in 20 years. And as a result, we didn't really have a lot of research or even more public discussions about how common these experiences were, just more broadly. So I started digging into the literature and realized that the work that had been done previously was very limited, a very small sample, very geographically restricted sample, or often just asking about current symptoms of psychiatric problems, as opposed to, well, what's the lifetime experiences that folks are having, right? So I got fortunate that when I started at Texas Tech, that came with a startup package. And so I had some funding and I said, I now get to decide what I'm going to do with my work and I can collect these data, which led to this project where essentially we did a systematic gathering of publicly available email addresses tied to all accredited doctoral training programs in the US and Canada for what we are sort of referring to as applied psychology. These are psychology programs that would tend to lead you towards a license and towards some type of clinical practice in either clinical counseling or school psychology. So we pulled from available databases of accredited programs. We went through all their websites. We pulled all the emails, we checked them, double-checked, triple-checked, sent out about 9,000 emails, broke my email account for a day. IT was unhappy with me. Had a little under 2,000 people respond, which I think is not bad. And in order to avoid biasing the sample, we described the study as a study focusing on the development of research and clinical interests, which was also part of the study. We did ask about those things, but we didn't say this is a study about lived experience of mental illness because we didn't want our estimates to be biased in that way. In terms of who actually answered our mental health questions, it was a little under 1,700, just because they were sort of midway through the survey and there was attrition. So what did we find? It turns out that, in fact, a very large proportion of people in these training contexts have lived experience of some kind of mental health difficulty. These numbers are actually not far off from well-validated general population estimates, if you look across the lifespan, right? We asked two separate questions. Mental health difficulties broadly defined. We let people define that on their own, and that was a little over 80%, so 4/5. We also had a question that involved a little bit stricter of a definition. We said, has a professional ever diagnosed you with a mental health condition? And even with that, it was still about half. The reason we did it this way was recognizing that not all mental health difficulties are diagnosable conditions. So for instance, suicide and self-injury are not themselves diagnosable conditions. And not everyone has access to care to have a diagnosis. And we know not everybody's even told if they're given a diagnosis, right? So we estimate that the true prevalence is somewhere between these numbers. Most people said that their first onset of some kind of mental health difficulty was before they started graduate training. So this has relevance for who we admit, how we support our trainees. And most people said that at least some of these difficulties were ongoing or recent. In terms of the specific types of difficulties that people reported, they could check any on a list of probably 40 or 50 different categories of conditions. We tried to cover every category in the DSM. These are just kind of the top most common. If you want to know the whole list, it's in the supplemental materials for the paper. But these are percentages in the whole sample for faculty and for graduate students. Faculty are the darker yellow and graduate students are the lighter yellow. So, and the prevalence rates look, again, relatively sort of in terms of order of prevalence or order of how common they are, Similar to general population, we see that depression and generalized anxiety are the most common, followed by suicidal thoughts and behaviors. I'm kicking myself that we didn't separate out thoughts from behaviors here. My bad. But again, seeing that those are quite common over the lifespan, as well as then social anxiety disorders, eating disorders, panic disorder or panic attacks, non-suicidal self-injury, and PTSD. We also asked people, have any of these mental health difficulties ever caused you professional problems? And about half said, nope, no professional problems. Within those who said that they have caused professional problems, they were generally mild and most commonly in research and in coursework. Now, that being said, there is certainly about a third of folks saying that they had some level of difficulties in their clinical practice, which is not something we should ignore. But I think it can also speak to the assumption that if somebody has a psychiatric condition, it's inherently going to cause work problems or inherently going to make them an ineffective clinician. And our data do not seem to support that assumption. Now, all the data I've presented so far are from clinical counseling and school psychology graduate training programs, but I realize I'm in a psychiatry department, so I wanted to also talk about MDs and DOs. These are data collected by other research groups. So this is actually a relatively recent paper looking at data from first-year residents or interns, specifically regarding reporting disabilities. And in this case, about 12% had some kind of disability, and those were primarily ADHD or chronic health or psychological conditions. And in general, what people said was that those who did not want to request accommodations, it was because of fear of stigma or bias. This is also replicated in a sample of year 2 medical students. So this is a very, very large data set in which about 9% reported a disability, and the vast majority of those disabilities fall within cognitive, neuro, learning, or psychological. The good news is that of those who actually requested accommodations, most of them are getting the accommodations they request or don't feel like they need accommodations. However, we do still see there's about 13% of people who said, yeah, I need accommodations, but I'm not requesting them. And although they didn't ask people why in this study, it's probably related to what we saw from the prior study in terms of fears or concerns about how that's going to be perceived. It's not just in training settings either. These are data from a Dutch academic medical center that compared non-resident and resident physicians assessing clinical cutoffs on a variety of different constructs. And we see that these percentages are not that different between residents and non-residents. Anxiety does seem a bit higher in residents, which anecdotally doesn't terribly surprise me. But this is to say that this isn't just a question of these difficulties in the context of training. And of course, all of these things together are extremely relevant for understanding the crisis of suicide in healthcare professionals. These are data based off of the National Violent Death Reporting System, which is a CDC program that pulls coroner's reports and other death-related data from a number of states in the US. And this essentially is the rank order list of health professionals, suicide death rates, divided by the number of professionals in the US in those categories. And what you see is that psychiatric physicians are actually the top of the list. In another study is similarly looking at NVDRS data, comparing physician and non-physician suicide deaths. We saw that some risk factors for suicide in physicians were actually less common in physicians compared to other non-physicians who died by suicide. So the death of friends or family or a personal crisis in the 2 weeks preceding the death, but that job problems were over 3 times as likely to be identified as a precipitating factor for suicide deaths for physicians compared to non-physicians. So I think that this is really critically important to think about the ways that we're talking about and thinking about mental illness and mental health in our professional roles, not only because of how it affects our clients and patients, but how it affects us as professionals and our own well-being and the ability to seek help in the context of job stress in medical and psych professionals. So why is this a problem? Why Why aren't we able to kind of address these needs, right? In theory, psychologists and psychiatrists and other medical professionals, we should know what treatments are out there. We should be able to go get them, right? Well, there's a lot of barriers to accessing care and to being able to bring up these topics in our professional context. So when I'm talking about brick walls and invisible fences, I'm thinking about both really obvious structural barriers as well as more invisible or attitudinal barriers. So thinking about attitudes, practices, and policies. One thing that really surprised me when I started digging into this literature was the issue of provider stigma. As I said earlier, the idea is if you have more contact with members of a stigmatized group in sort of general population studies, that seems to be associated with lower endorsement of stigmatizing views. And yet we actually find in studies that compare health professionals to the general public that health professionals tend to report greater stigma towards mental illness, including mental health professionals, compared to the general public. So these are data, I believe, from Italy, from Magliano and colleagues, where they asked these samples of the general public and mental health professionals, you know, what do you think about these statements about people with schizophrenia? And I was honestly somewhat shocked by some of these discrepancies. So, you know, the last line here says a person who's previously suffered from schizophrenia and has recovered, so that's sort of stipulated in the question, could work as a babysitter. And only about half as many mental health professionals say yes compared to the general public. Why? Why is this, right? In theory, if we're working with these folks, that should be helping us to reduce stigma. Well, Cohen and Cohen, back in the 1980s, posited that one of the drivers of different views of the sort of treatment responsiveness or hopefulness of clinical course for these conditions might be influenced by what subsample of these populations you're getting exposed to. So in the Cohen and Cohen manuscript, they talk about the clinician's illusion relative to researchers, with the idea that clinicians are going to potentially view some psychiatric conditions as being more resistant to treatment or having a less hopeful course, because almost by definition, they see people who are in distress. They see people whose illnesses have not resolved, right? If you're a clinician, you're probably working with people who have had a relapse of an episode. Whereas if you're a researcher studying a condition, you might recruit people across the severity or chronicity spectrum. And this also applies even within clinical practice, that folks who are in settings where you see people who are more acutely ill, who have been ill for longer, are going to then have less hopeful appraisals of the possibility of recovery for these illnesses. So for instance, if you work in an inpatient setting versus an outpatient setting, your experience of what depression looks like in terms of its ability to have somebody fully recover might be very different, right? You can also just think about epidemiologically, if somebody has one episode of depression, they might see one provider or no providers. If somebody has 2, 3, 4, 5, 6 episodes, they might see multiple providers. So that person is then being sort of sampled as an exemplar of depression by more people. So this also, of course, has implications in terms of our stigma towards folks who have suicidal thoughts or behaviors. In Germany, they looked at medical trainees and the general public and practicing professionals and found that trainees didn't seem to have a huge difference from the general public, but professionals who actually work with suicidal people had higher stigma. And this has tremendous implications for the way that we then talk about suicide risk among professionals. So this was a large survey by Shanafelt and colleagues where they asked this big sample of physicians, would you be willing to seek help for a serious emotional problem? I don't know how they define serious. Overall, about 3/4 said yes, but there was this significant discrepancy between physicians who reported suicidal thoughts in the last year and physicians who did not. So the physicians who said that they'd had suicidal thoughts in the last year were much less likely to say that they were willing to seek help. Now, I'm glad that that's still 64% said yes, but you're seeing about a 10% drop there. Why? Why is that, right? In a couple slides, we'll get into that specifically. A lot of these fears are not unjustified. You know, we talk about fears of stigma as being hampering to disclosure and hampering to help seeking, as though the fears themselves are the thing we need to address. But in many cases, the fears are based in actual experiences and actual negative consequences. So these are data from a study of ACGME program directors who were sent experimentally manipulated vignettes describing an applicant to their program who was either put in the context of a sort of perfect application or a good, like a really solid application, where the person either disclosed experience with depression or experience with type 1 diabetes. And then it was experimentally manipulated what their other credentials looked like. And in the good credentials condition, the applicant also had a medical leave of absence related to the illness that they disclosed. So they then compared them to an average applicant. And this essentially shows the proportion of the program directors and how they rated those different theoretical applicants in terms of how likely they were to offer them an interview. So the good news is that the folks who in this kind of experimental design had disclosures of depression and type 1 diabetes with perfect or good applications were still rated as more likely to be invited for interview compared to an average application. So that's good. However, we found that within these categories, there's quite a significant discrepancy between disclosing type 1 diabetes and disclosing depression, right? So essentially the darker gray bars here, the darker that the bar is, the more likely they are to offer an interview. The way they sort of scaled this makes it a little tricky in terms of interpreting the odds ratios. But what you can see here is that even within the perfect category of applicants, the one who self-discloses depression has far more of the lighter bars compared to the person who disclosed type 1 diabetes. And then in the good application, you see that's even more apparent. There's also significant implications for licensure. So in a study by Derby and colleagues, they actually reviewed all licensure applications for new and renewal licensures for physicians in the 50 US states. And they rated whether their questions about mental health and mental illness were consistent with best practice guidelines in terms of only asking about current or recent potentially impairing conditions. And then rated them as inconsistent if they were asking about, for instance, lifetime conditions or not specifying that they had to be professionally impairing. Only about a third of states had licensure applications that were consistent for both new and renewal licenses. I should say this is from 2014. These data were pulled in 2014 to 2016. So hopefully, maybe it's a little better now, but given how slow some of this stuff happens at the state level, I can't imagine it's dramatically different. And then at the same time, they surveyed physicians in all 50 states regarding whether licensure concerns would impact their willingness to seek formal mental health care. And in the total sample, about 40% said, yes, that is a factor that I would consider in being willing to seek formal mental health care. And there were significant differences across states in that physicians who resided in states where their licensure materials asked these questions that were not specifically limited to current or recent impairment were more reluctant to seek care. So we're seeing, potentially significant evidence that people are taking these things into account, understandably so. And honestly, this was really sort of disheartening when I take into account the fact that we've been having these conversations for quite a while. This is a snippet from an article by Kay Redfield Jamison in The Lancet in 1998, talking about her experience disclosing her bipolar disorder and the reactions that she got, many of which were somewhat difficult for her, but this highlighted section really identifies that even at that point in the 90s, she was saying she was getting hundreds of letters from doctors and other professionals recounting their own experiences, the lack of support that they'd received, and often dismissals from medical school and residency programs, and their concern that they could not be straightforward about their mental illness because of concerns about their degrees, licenses, and hospital privileges. So the fact that, we're talking about 15, 20 years later, and these are still things that are really, really salient, is disheartening. And lest you think that that's just a problem for the MD-DO side, this is also a problem in the PhD side. It's very common that when folks are thinking about applying to PhD programs in psychology, they're told, do not disclose your lived experience. It's all risk, no reward. In fact, a really classically cited study from Appleby and Appleby from 2006 surveyed directors of clinical training and asked, what do you view as kisses of death in the graduate admissions process? And then they took all that qualitative data and synthesized it into themes. The number one most commonly described kiss of death was a damaging personal statement. And the number one most cited specific example of what would be a damaging personal statement was disclosure of personal mental health. So again, this is common advice and likely based in some justifiable concerns about stigma. What I think is really challenging about some of these structural factors and some of these attitudinal factors is that they create this vicious cycle where people are advised not to disclose due to very reasonable, understandable, factually based concerns. Therefore, non-disclosure becomes the norm. And then if somebody is going to disclose, it's typically motivated by some pretty significant need, right? In order to get over that hurdle of non-disclosure as norm, when people do disclose, it's more likely to be because, for instance, they need to take a leave of absence, or they're looking for service providers, or some problem has come up in their training. Because that might sort of get you over the hurdle of, well, I don't want to disclose, but I don't have a choice. I need to. What then happens is that the examples that people have of when folks have disclosed are going to be selectively examples where those experiences with psychopathology or mental illness have been impairing. And then as a result, people will continue to advise you not to disclose. I've had so many conversations where more senior faculty have said, well, I understand what you're saying, but I had this student one time and they really struggled and they had to go on a leave. And I say, okay, I believe that. And do you really believe that every other student you've had that has been super successful, that none of them had any of this stuff going on? And then they sort of pause and look a little flustered. Right? Because the people who are having these experiences either before graduate training or that aren't impacting their work, they're not telling you, right? So there's no counterexamples. So it's understandable why this happens. And it's part of why I've added this into my work, to be able to say, well, maybe if some of us who are in positions where we feel secure enough to be able to say, hey, actually was totally going through depressive episodes in grad school, still made it out, might be able to change this narrative a little bit. And I do think that there's progress on kind of bigger fronts as well. This is Dr. Devika Bhushan, who served as the acting Surgeon General of the state of California a few years ago, and came out publicly about her experience with bipolar disorder at that time, which was really impactful and got a lot of media attention at that time as well. I did also want to mention briefly that beyond kind of the licensure side of structural barriers, there are a lot of other structural barriers that folks may be facing. So, for instance, receiving involuntary treatment can come with a lot of downstream legal consequences, in terms of things like child custody, ability to own a firearm, things like that, as well as things like health insurance and access to care. This is something in clinical psychology doctoral programs we struggle with a lot, because often our training settings for our graduate students are the places in the community that serve students in other departments or that provide sliding scale or low cost services. And so, if a graduate student or a faculty member needs services, they may not want to go to a place where their students or their colleagues are, practicum students, for instance. When I first moved to Texas Tech in Lubbock, we're in a health service provider shortage area, and I wanted to find a psychologist who is well-trained and who I could establish care with. And I found someone who was not affiliated with our department. And I explained the situation, and he said that was all fine. And, occasionally he serves on some committees in our department, but not a problem. And I stopped seeing him, just wasn't a good fit. And I found out about 6 months later that he has a regular poker game with my department chair, who was then my department chair, and the most senior tenured faculty in my program. So if I had ever been invited to that poker game, which I was not, I would have ended up sitting across the table from, my chair, the people who are going to vote on my tenure, and the guy who I see for therapy, right? So challenges. Okay, so this is a part of a Maya Angelou quote. The larger quote is, do the best you can until you know better. And then when you know better, do better. So recognizing there's a lot of, challenges in this area, and there's a lot of work to be done. And there's also a lot of possibility of things that can be done both at large structural levels, but also at the interpersonal level in the work that you all are doing with your colleagues, with folks that you might be training in all sorts of these environments. So thinking about sort of next steps and where we go from here. Why should we do anything different? I'd sort of hope by this point in the talk that I don't have to really try to convince you of this, but I think it's worth it. First, because it's relevant for principles of equity and disability justice. Now, I should acknowledge that certainly not everyone who has a history of mental health difficulties or mental illness necessarily would describe those as a disability. So there's intersection there, but not complete overlap. But this also speaks to the importance that we place in our healthcare professional training pipelines around having a diversity of perspectives and experiences and values. You know, if we are sort of at the forefront, cutting out folks who are willing to disclose these experiences, we're losing a huge opportunity to include those values and those experiences in the way we think about patient care and the way we think about building our fields. I would also hope that having those experiences can improve the relevance of some of the research and the treatments that we're doing. I can certainly say that my experience as a client and as a patient certainly impacts the way that I train graduate students and the things that I think about teaching them and, you know, reflecting on those experiences, in addition to, of course, all of the other training I have. And there's some data that suggests that providers with personal experiences relevant to mental health and mental illness report lower stigmatizing views of clients with psychopathology. So just to kind of contextualize, a lot of the recommendations that I'll be talking through are drawn from these two papers. The one in the upper left corner is a commentary that went along with the empirical paper I described earlier. And then the second is a commentary focusing specifically on folks with experiences of non-suicidal self-injury. That community sometimes has unique experiences relevant to the fact that they might have visible scarring and so may have to navigate things like inadvertent disclosures. So just to sort of self-cite myself that these things are elsewhere. So broadly thinking about structural change, one thing that's really critical is to think about gathering more data and understanding what these experiences look like across groups that are diverse in a variety of other ways. So our data, you know, 1,700 people is certainly a large data set, but we didn't have the ability to really start to dig into, for instance, racial and ethnic differences in terms of diagnoses and help seeking and experiences, because overall the sample was primarily non-Hispanic, Latinx, white. And so those subgroups were a little too small for us to kind of statistically say anything that we felt really confident in. And yet we know in medical training and psychology training, there are big institutions that do big surveys. You know, the studies that I cited earlier, particularly from the medical side, it wouldn't be terribly hard to start asking more of these questions and to be able to then understand more nuances about how different program characteristics, different individual characteristics are relevant, and to track changes, hopefully improvements in kind of the ability for people to disclose and have these experiences understood over time. I also think we need to do a much better job in transparency in terms of when and how disclosures are or aren't going to be ideal. So I personally hate the term personal statement for admission to graduate programs because we generally are not asking for much personal stuff. We're asking for kind of a professional statement of goals or a research statement of research interests. But because we call it a personal statement, unless you have someone to kind of guide you through and clue you into the hidden curriculum of, hey, when they say personal, they don't actually mean personal. It really disadvantages particularly folks, you know, who may not have someone in their corner to say, actually, don't put that in there. So to say whether this is something you want in the statement or not, or how it's going to be evaluated. Also, critically, we need to increase supports and resources for folks struggling with mental health and mental illness in the context of our training and our professional lives. So this can look like reducing barriers to help seeking, making sure that we have excellent health insurance to cover mental health care, making sure that there are lists of places to go for services that don't potentially pose a dual relationship or a conflict of interest with a training program, and making that information publicly available up front so people don't have to ask for it. Because oftentimes if you have to go to your director of training and say, can you give me a list of places, that's already a huge barrier. Also critically important to differentiate understanding people's lived experience backgrounds from the possibility of professional impairment. We know that those things are not synonymous. You can experience professional impairment that is totally unrelated to your mental health. And lots of people can have mental health experiences, conditions, difficulties, diagnoses that don't cause professional impairment. And the more we talk about those things as synonymous, I think the more challenging it is for people to disclose and be effectively and fairly evaluated and trained. On an interpersonal level, I think it's important to remember that every human being views the world differently on the basis of our experiences and our identities. This is just sort of a foundational truth of how humanity is. And so not to assume that people who have a personal experience relevant or not relevant to their work, that those people are biased compared to these people who are somehow not biased. The truth is, we as humans are biased. And so rather than trying to say, well, we're going to select this group out and therefore rid our field of bias, just say, well, all of us have our own preconceptions. How do we check those, right, across settings? And of course, if you have a personal experience and you're working with someone whose experiences or diagnoses may overlap with your own, recognizing that that person is also still a different person than you. Their experience of their condition, of their symptoms, very well may be totally different, and the treatment they need may be totally different than what worked for you. Again, interpersonally preparing to learn about other people's lived experiences, think about how you want to respond before it happens so you're not standing there like, flustered, right? Being effective, non-judgmental, empathetic, and thinking about what the goals and needs are of the person who disclosed to you, and what you're going to do with that. And then ideally not sharing that information with others unless you have that person's permission, treating that information the same way you would treat a disclosure relevant to any other potentially stigmatized experience or identity. Also critically important to prepare to be asked. So it happens not infrequently that, a teenager I'm working with might say, well, what do you know about XYZ, or someone will ask, well, how did you get interested in that work anyway? Do you have experience with that? If your answer is yes, that you do have some personal experience with that, you don't owe that information to the person asking. You get to decide when and how you disclose that information, and you can and should do that when it's consistent with your goals. So you might consider how you want to answer those questions depending on the context. But it's just as important that people whose answer is no think about their responses as well, because the way that you answer sets the tone for everyone else who's seeing your response about what you perceive as acceptable. I have seen a number of folks get asked, well, you study suicide. Do you have any experience with suicidal thoughts? And the response has been, oh, no, that's not something that I've ever experienced. No, of course not. Don't be silly. And you're just standing there like, okay, you have now made it very, very clear that nobody in this room whose answer would be yes is going to talk to you about that, right? So think about that as well. Think about how you can model openness and dialogue regarding these things. I teach introductory graduate psychopathology, and I make sure to assign readings from first-person accounts of many of the conditions that we talk about as sort of a counterpoint to the DSM that they're reading and then scientific articles. And avoiding language that sort of otherizes or separates patients or clients from providers, recognizing that many people wear both hats. There's also good news that there's at least some work being done in sort of interventions to target stigma and bias. So I was excited to read this paper by Martin et al., where they randomized medical students to receive an intervention that involved self-disclosure of mental illness history in practicing physicians. And they showed that that intervention group actually had significantly improved attitudes towards mental illness and improved willingness or interest to consider the field of psychiatry compared to their own pre-intervention baseline and compared to the control group, which did not change over time. And they all said that it should remain a part of their training. Finally, I think we can all think about ways to advocate for change. So considering experiences relevant to psychopathology in the context of broader goals related to diversity, equity, and inclusion, thinking about building from other communities to build on strategies and programs that support other folks with marginalized identities and potentially concealable ways. So thinking about allyship programs, mentorship programs, encouraging people with lived experience in leadership roles, and then advocating for changes in the licensure process, particularly for those states where we're still seeing questions that seem to go against ADA. So I'll stop there. I want to thank all the folks that I've gotten to work with on all of these and other projects, especially my mentors, most of whom don't do this work, but who have been extremely supportive in seeing me pivot a little bit to start including this in my portfolio. And then I've got my contact information on the bottom I'm happy to take questions now as well as via email or anything after that. And all the papers that I talked about are on our website. And also reference slides that I'm happy to send around after if they're helpful. Thanks.
Thank you very much. Do we have any questions in the room?
Thank you for just a very wonderful talk and for your vulnerability and sharing and also the very thought-provoking data. I'm wondering, do you have similar experience or recommendations for substance use disorders? Because I can imagine that the stigma and also the potential risk might even be higher in that realm. And so I'm just curious kind of how things would be similar or different when you're thinking about self-disclosure there.
Great question. So we did include substance use disorders in our sort of list of specific difficulties. They were not zero, but they weren't in sort of the top 10. Interestingly, substance use disorders was actually the only category looking at the specific diagnoses that were more commonly reported in faculty compared to graduate students. Every other one was more common in grad students compared to faculty. I don't have specific hypotheses about that.
So maybe.
Yeah, I don't know. It is really interesting because on the one hand, we know certainly like acute substance use, like coming to work intoxicated would, likely be something that you're thinking about professional impairment. And yet the field of substance use interventions actually has a longer track record of including sort of peer support or folks in recovery in their treatment teams. Like it's considered more normative to be open about those things, like being in recovery and that being sort of a key component of being a part of a treatment team. So I have lots of thoughts. I'm trying to think of how to sort of frame them. I don't have any sort of specific recommendations for how you might address that other than that it's going to vary person to person. And I think the same way that we see that a lot of these conditions aren't necessarily professionally impairing. It's also certainly possible that a substance use disorder wouldn't be professionally impairing, even though it could be, a serious condition worthy of treatment.
We have a couple of questions from the Zoom crowd. What are some policies that can be put in place to help support mental health and medical providers who experience mental health struggles?
Oh, I have lots of thoughts about that. A few different policies. So I think the first is making sure treatment information and access is freely given throughout training so that, again, people don't have to ask for it, where you would go, how you would get access to care, who might know about that depending on what setting you're in. I think policies around leaves of absence can probably be changed in ways that could be more supportive. So for instance, in many cases, if you take a leave of absence, you lose health insurance. At least that's how it works for like our graduate students if they take a leave of absence, which is totally counterintuitive. Like if you're taking a medical leave, it seems pretty critical that you would not lose your medical insurance. So to the extent that programs have the ability to do some sort of bridge funding so that folks who need to take a leave of absence can ideally at a minimum still keep their health insurance, and even more ideal would be continue to get paid. Thinking about that as well. So ways to, keep up financial supports for faculty, medical leaves, I feel like are very tricky because faculty, a lot of our roles don't stop if we're on leave. So I think trying to be strategic about what kinds of accommodations could be put in place, whether it's, course releases or hiring somebody on kind of a temp basis to take over grant management, things like that. Other policies, paying trainees more. I know that sounds like a throwaway, but we know that earning a living wage and reducing financial stress is huge. Having the ability to pay for care.
Having time to go to care.
Yeah, having time to go to care. So that's more, and that's something, thanks for mentioning that, because in psychology, in the PhD world, your schedule is often very, very busy, but in a more flexible way where I don't know where my graduate students are on any given day. I just know that they're working on stuff. But for MD and DO trainees, you're often, getting an hour to leave during business hours can be really challenging. So trying to address that and making sure that you're not penalized for asking for that time and that support.
We have a question from Dr. Laura Kelly, who thanks you for your talk. Question is, do you have additional practical advice for cultivating such research teams that are truly embracing lived experience and creating these genuine partnerships among researchers and staff who may have varying types of lived experiences and disclosure of such experiences?
Yes, great question. I do have thoughts. One is to try to build that infrastructure outside of the context of a specific study or a specific grant. That is really hard to do because typically to get money to pay people to be a part of your team, you typically need money like a grant. But oftentimes by the time you get money to do a specific project, a lot of those decisions have already been made such that if somebody from your kind of advisory team says that's a dumb idea, you're a little bit in trouble, right? You've got the grant money to pay the team to tell you that it's a dumb idea, but you can't just not do the idea. So to the extent that there can be institutional resources to support building up that, the ability to build those teams at the start, I think is helpful. Other kind of practical recommendations, paying people for their time. That's important. Continuing to recognize that folks, just because someone hasn't disclosed personal experiences doesn't mean they don't have them. Is also important, but also, in terms of having conversations about how lived experiences can impact work, the folks who aren't feeling comfortable to disclose are going to have a much harder time than using those experiences to tell you something about your project. Building in strategies for people to tell you stuff that you might not want to hear, I think is helpful. So thinking about how you personally are going to respond if someone tells you something that you don't want to hear, or how you can allow for feedback if people don't feel comfortable saying that to you directly. And what I mean by that is, depending on people's lived experiences, the sort of starting base of the work may be totally different. In suicide prevention, historically, a lot of the lived experience emphasis has been from family members who have lost someone to suicide. So what we refer to as suicide loss survivors. Those people have a very strong sort of impact on suicide prevention priorities, research, advocacy, as they should, right? But if you have lost someone to suicide, you're going to have a different perspective on, for instance, involuntary treatment than someone who themselves has been acutely suicidal and has had experiences being involuntarily hospitalized. And the field has, in the last maybe 5, 10, 15 years, started to include more people who themselves have had experiences of attempts, involuntary interventions, police interventions, et cetera. And their perspective, folks in that community feel very differently about, if your study is going to involve inpatient treatment compared to the families of someone who has died, where they say, I would do anything to have my person back, even if it means they have to be in a hospital against their will. So recognizing that you may have disagreement among people in sort of the lived experience community about where to focus your efforts most.
Any other questions?
Hi, I'm a visiting medical student. I'm a fourth year student. So I submitted my ERS applications 2 days ago. So this is very relevant. My question essentially is, there's increased conversation about mental health, especially after COVID, but it results in like a pseudo or like a checkbox of solutions. So programs will mention wellness, but they won't mention about psychiatric services that they provide. So how do you address these pseudo solutions or placeholder solutions?
Oh, that's a really good question. I think it would be a two-pronged or a multi-sort, both and, like, good job including things about wellness, like keep doing that, right? Like, even if it's not at sort of a clinically, where folks are necessarily at sort of a clinically experiencing symptoms level, like wellness is great, do that. But also to say to programs, you need to also add in these other things. I think, I had a thought about it and it's just totally lost out of my head. I think anytime programs are implementing these new things, there needs to be a way for the people impacted by those changes to provide feedback on whether it works or doesn't work. And that can be tricky if you're in like small programs where it's hard to sort of de-identify those data. But if there are ways that programs can actually ask the people in the program, like, hey, we care about mental health. This is what we've done. What do you think about that? Should we keep doing that? Should we do anything else? And then actually using that information. Because also, like, my personal pet peeve is if you're going to ask people for feedback on stuff, you have to do something about the feedback. You can't just ask for it and then just let it like sit there, right? People are spending their time and effort to give you feedback. That doesn't necessarily mean you need to do every single thing that every person who filled out the form says to do, but you need to engage with it in good faith. So that would be my recommendation for programs, is to be soliciting that. And then to be willing to hear, hey, you did this and it actually felt kind of tokenizing and like it wasn't super supportive. And then like sit with that and do something about it.
So I really appreciate your talk. It reminds me of, I heard someone speak about suicide rate amongst physicians in the United States and put the statistic this way, that every year we lose an entire graduating medical class to suicide. Thank you very much.